Okay, so I think we'll start now. So it's a pleasure to have Dr. Dilraj Grewal of Duke University here. He's an associate professor of ophthalmology. He specializes in retinal diseases and uveitis or inflammation. Basically, he's both a practicing clinician and an active researcher, a recipient of numerous awards from the American Ophthalmological Society and so on. So he'll be telling us about retinal imaging and neurodegenerative diseases. Over to you, Dr. Dilraj. You're muted, Dr. Dilraj.
I'm sorry. Thank you so much. And thank you for the invitation to join you.
You make it into presentation mode?
Yes. Is that okay?
Yes. And also, if you are okay with questions during your talk, I can request audience members to just say question and then I'll alert you.
Yes, that'll be fine. I think we have, my talk will be about 15-20 minutes. So we'll have enough time for questions if you wanted to just interrupt anytime. And I'll be talking about retinal imaging in neurodegenerative diseases. These are my financial disclosures. None of these are relevant to this talk. Now, I understand that this audience is maybe a little unfamiliar with ophthalmic imaging, particularly in the context of neurodegenerative diseases like Alzheimer's. So I just wanted to start the talk by first emphasizing why should we care about neurodegenerative diseases like Alzheimer's. So the number one issue is that the prevalence of Alzheimer's dementia is expected to increase exponentially as our world ages. So for example, just in the United States, over the next 20 years, the prevalence is expected to more than double, particularly in older Americans. And this goes along with the fact that people are living longer, so therefore their cognitive function is expected to have a larger time window to show a decline and have a larger time window when they live with conditions like Alzheimer's disease. So why is it important to try to detect this early? And where does retinal imaging fit in? As you know, there is no definitive cure for Alzheimer's disease. There are several drugs that have been approved by the Food and Drug Administration recently in an attempt to reduce plaque burden. But the bottom line is that there is value of protective factors that can be introduced if patients are diagnosed early. And these include the factors like education, physical activity, diet, controlling lifestyle, controlling health conditions. And these are important and are effective, but only at the early stages of disease. So if you look at the progress that has been made, we have made good progress in controlling cancers, controlling cardiovascular diseases, excellent progress in controlling infectious diseases. But yet the rate of neurodegenerative conditions has increased exponentially. And if you ask people, when would they want to be diagnosed with conditions like Alzheimer's dementia or even Parkinson's, the vast majority state that they want to be diagnosed in situations where they still have what is known as mild cognitive impairment. This is prior to the onset of dementia. And the reasons for this are manifold, including the fact that environmental and lifestyle changes may play a role at this stage, but also so that they can plan their life ahead of them appropriately. So where does the retina come into all of this? There is value of looking at the retina in neurodegenerative conditions because of the fact that the retina and the brain share a common embryologic origin. So therefore, there are many similarities in the tissue that is seen in the retina and in the central nervous system, and the retina is considered to be an extension of the central nervous system. It's also a unique tissue because it is optically clear, allowing us access to visualize it directly, non-invasively, and in a very rapid manner as our ophthalmic imaging has advanced, particularly over the last 10 to 15 years. There is also an increase in other neurodegenerative conditions, for example, Parkinson's disease. And these are expected to contribute to disability and deaths faster than any other neurological disorder. And there's overwhelmingly a shortage of neurologists to be able to diagnose these patients early on and conduct appropriate screening. So access to care remains a major issue. So that's why there's even more impetus to develop non-invasive, ideally non-invasive biomarkers that allow us to detect these diseases early, including blood-based biomarkers, MRI or PET-based biomarkers, or retinal imaging, which can offer the advantages of rapid ability to obtain images, as well as low cost of acquisition for repetitive imaging. So I wanted to introduce the concepts of imaging the retina using OCT, which is basically optical coherence tomography, or an optical ultrasound of the retina. The neurosensory retina is composed of 10 different layers, and you can see on the image on the left, these layers are represented by different shades of gray. We have the ability to capture near histological level of detail at about 5 micron resolution anatomy of the retina and visualize these different layers. We can then segment these different layers and obtain thickness maps of individual or combined retinal layers. So this allows us to visualize layers like the retinal nerve fiber layer or the ganglion cell layer, where the axons of the neurons, lie, which then lead into the optic nerve. And construct thickness maps like you can see in this figure here with the blue and yellow overlay that gives us the thickness of the ganglion cell layer, or whichever layer of the retina you want to look at, in a particular area in the center of the retina. Similar maps can be constructed for the entire thickness of the retina. We also have the ability to obtain even higher resolution imaging using OCT, that is termed as OCT angiography, which allows us to visualize change in the red blood cells as they flow through the different capillaries, blood vessels in the retina. And doing so then allows us to reconstruct an en face vasculature of the retina that is known as an OCTA image. And you can see in this top right image here, this is a reconstructed image showing the pattern of blood vessels in the retina. This data can then be used to measure the density of these blood vessels, a term that is known as vessel density, or the amount of vessels that are seen per unit area if we binarize each vessel down to 1 pixel width. We can also measure something that is known as perfusion density, which is the total area occupied by the vessels per unit area. So you can see in these color-coded maps that are at the bottom right of the image, these are maps that are showing the vessel density distribution and the perfusion density distribution in the central macula. And this is a scan that encompasses a 6 by 6 millimeter area. The center part that looks blue is known as the foveal avascular zone, and that's a naturally avascular area that is present at the foveal center. We are also able to use this technology to image the area around the optic nerve. The area around the optic nerve, or the peripapillary area, has a distinct complex of blood vessels that is known as the radial peripapillary plexus. And these are blood vessels that then feed into the larger vessels that go into the optic nerve. And we are also able to construct vessel density maps and use terms which are defined as the capillary perfusion and flux index to look at the density of vasculature around the optic nerve. So using these data, we can look at patients that have neurodegenerative diseases, because neurodegeneration results in loss of tissue, and it also results in loss of microvasculature. We know that these changes occur in the brain in Alzheimer's, Parkinson's disease, and even mild cognitive impairment. And our thought when we started out this research was that we could potentially pick up these changes at a much earlier stage because we are able to image blood vessels at a much greater detail than using, for example, MRI or PET-based imaging or cerebral angiography. And that is what we have been seeing, that in patients that have neurodegenerative diseases, there is a reduction in their vessel density as well as perfusion density. And you can see in this image on the left, the top panel represents a healthy control that is cognitively intact. And you can see the pattern of the capillaries and the blood vessels in the macula, and then a thickness map of the vessel density and perfusion density. The two circles represent grids which are 3 millimeters and 6 millimeters in diameter. And these are obtained from the early treatment of diabetic retinopathy, or the ETDRS study, and are standard areas of measurement to look at different parameters in the macula. So it allows us to obtain a standardized area to be measured across time and across different cohorts. So we use the areas inside the smaller circle and inside the larger circle, as well as the total area, to measure different regions of the macula as we try to assess for change. The area within the central 1 millimeter is mostly avascular. So instead of measuring that area, we measure instead the area that is included within the foveal avascular zone, or the FAZ. We can also use these cross-sectional measurements to obtain thickness maps and values of different layers like I had shown, and also use it to image the choroid, which is the layer underneath the retina. And we have also seen that as there is progressive neurodegeneration, there is also thinning of the choroid. And we have worked with collaborators in Singapore to measure the choroidal vascularity index and shown that there is a reduction in neurodegeneration when you compare patients who have Alzheimer's and Parkinson's to similarly aged and sex-matched control patients who have normal cognition. Now, what are some of the important parameters that need to be kept in mind when you're looking at retinal images? Because these are high-resolution images, it is very, very important to keep in mind that image quality needs to be adequate in order to try to use this data for any sort of quantitative analysis or any machine learning analysis. And that is true for any kind of image-based data set. OCT, and particularly OCT angiography, is susceptible to artifact that includes motion, projection, shadow artifact, which is even more critical when you are scanning patients that have cognitive impairment. It can be difficult, particularly for patients that have more severe stages of the disease, to keep their head still and in position and keep focused on the scan during scan acquisition. Each scan by itself takes about 2 to 3 seconds, but there is a set of scans that we need to obtain for each eye. So the total set of imaging per patient may extend from between 5 to 10 minutes, and that can be significantly longer if they are unable to cooperate. It's also important to keep in mind that we need to exclude other ocular comorbidities which can impact these measurements and that can impact scan quality. So in an effort to automate the process and the pipeline for obtaining and sorting through good quality images, we trained a model to recognize what is a good quality thickness map of the ganglion cell, and that's shown in this middle column on the top panel, and also what is a good quality image of the superficial plexus of the blood vessels, or the superficial capillary plexus, which is the top panel in the right column. And then as we ran our images through it, we trained it to sort the images into good quality images, which is ones that can be used reliably for quantitative data and for machine learning, and those that were of inadequate quality. And this serves as a good, robust, automated method to sort through the images, because as you can imagine, if you're obtaining multiple scans per eye and then both eyes per patient, we will quickly build up a very large repository of images. And because these are cubed images, there's a high density of data that these images include. So as we want to look through different layers, having a method to automatically look at the quality becomes very important. What about the repeatability of these measures? As you know, it's critical that any kind of metric that we are using to determine biological change needs to be repeatable, particularly when we are looking at tissue at the level of 5 microns, and particularly when the magnitude of change between an abnormal eye and a normal eye in neurodegeneration is small. So we have looked at the repeatability of these parameters in normal patients that are of an age in which you would expect neurodegeneration, as well as in patients that have neurodegeneration like Alzheimer's, mild cognitive impairment, Parkinson's. And I found that there is good repeatability of these metrics. We have collaborators at the University of Edinburgh that have been critical in allowing us to look at imaging beyond just OCT and OCT angiography. So as you may be aware, we are able to capture photographs of the back of the eye, and you may have heard of these being used for screening for diabetic retinopathy. But wide field pictures of the back of the eye or fundus photographs can also be useful to pick up changes that would suggest neurodegeneration like Alzheimer's and Parkinson's. And this is done by advanced analysis of the pattern of the vasculature. So similar to the microvasculature that is analyzed using OCT angiography, the larger vessels can be analyzed on fundus photographs. And this is done again by a similar method of identifying and skeletonizing the vessels. But then in addition to just measuring vessel density, we are able to also look at the branching pattern or the fractal dimension of the vessels. And we are able to look at how the vessels change as they go from the center of the eye towards the periphery. And we are also able to look at this in each quadrant of the eye. So for example, supranasal, temporal, intranasal, intratemporal. And this is another metric that has been shown to show differences in patients that have Alzheimer's and those that are of normal cognition. So analyzing the vessels is not new in dementia. When we conducted a review of work that has been done on this in the past, there have been efforts that have even been made at automating the detection of plaques in brain tissue. But the problem remains that the most definitive diagnosis of Alzheimer's is made post-mortem on pathological analysis of the brain. And all of our efforts are now trying to move that to a very, very early stage and non-invasive. And as of now, the gold standard has been detection of amyloid using PET tracers. But the efforts now are focused on detecting signal potentially at an even earlier stage. So what about change over time? We have been collecting data now for almost 7 years and have a database of patients that we have followed over time. And we are able to look at change over time as well. Now, it's important to remember that as we age, our retina changes, and there are normal age-related changes in retinal thickness, as well as loss of the vasculature in the retina that occur with aging. So it is important to try to recognize, are changes in neurodegeneration different than what we would expect from normal aging? And that is what we have found, that in patients that have Alzheimer's or Parkinson, and even in those that potentially have a genetic marker for Alzheimer's, there are rates of change that can be quantified. In those with the disease, they tend to progress faster than controls. But in those that have the marker for Alzheimer's but don't have the disease yet, there is not necessarily a difference over time. We have also looked at the repeatability of the peripapillary optic nerve parameters, and that's looking at the optic nerve head and looking at the capillary perfusion and the flux index and shown that to be repeatable, including in all the different cohorts. And then we have also used it to identify differences between patients with Parkinson's and Alzheimer's and normal controls. Now, this is a topic that that has not been that well studied, and that is specifically looking at these capillaries around the optic nerve. And there's still controversy in terms of what is the exact change that we are assessing here. Because in many regards, the change that we see in the peripapillary plexus is opposite of what we are seeing in the macula. So there may be even a potential increase in some of these plexus density. And whether this is a compensatory response or these are changes that occur independent of each other, it still remains to be determined. But it is a signal that has been seen and is consistent across the different cohorts. But we need more data. And this imaging of the optic nerve is more recent, so we don't have much longitudinal data on this. And this becomes a key issue in developing these biomarkers in general, because over time, our imaging capabilities advance, our image analytics advance. However, if you want to compare data across a cohort, our imaging has to be standardized, acquisition protocols have to be standardized, the software analytics have to be standardized. So very frequent upgrades can become challenging. And then again, coming back to the choroid, which is the highly vascular layer underneath the retina, this is also a promising area of investigation. And using what is known as enhanced depth imaging, we are able to visualize this layer. And then we are also able to visualize the different vascular layers within the choroid, which are the halars and satellars layer, and then look at the density inside the lumen of these choroidal vessels, as well as the area occupied by the remaining choroid, and look at that ratio. And that is also shown to be progressively thinner in those that have Alzheimer's dementia. And this is while accounting for age, because these are all patients that are similarly aged and gender matched, because it's important to recognize that there are normal age-related and gender-based differences in these parameters. There's also been correlations between what we are seeing on the OCT angiography in terms of reduction in their vessel density and perfusion density, and what we are seeing on MRIs or volumetric MRIs that are captured that are showing ventricular expansion as there is cerebral atrophy with progressive neurodegeneration. So expansion, particularly of the infralateral ventricle, has been shown to be associated with a decline in vessel density and perfusion density. And that's very promising. As you can imagine, obtaining a volumetric MRI is more cost prohibitive than obtaining a retinal image. So therefore, our cohort for this study is smaller. But this is important because if we in the future look to incorporate some of these metrics potentially in clinical trials that are being conducted, where PET scans are obtained routinely, such correlations become important. Now, what about change over time in disease? Now, I had mentioned that there are differences in the slopes or the rate of change and rate at which you lose retinal tissue and retinal blood vessels when you have a disease like Parkinson's or Alzheimer's. And what we have found, we recently looked at a cohort of patients with Parkinson's that were followed over a period of 2 years and found that the velocity or their slopes were significantly faster than those that were cognitively intact and what we would expect from normal aging. So in other words, these patients lose tissue faster, they lose vasculature faster, the retina thins out faster. And this is just a representative example here in the middle column, where you can see the vessel density map, even over a period of just 2 years, there is a reduction. The colors on the panel on the right look different than the colors on the left. And you can see the differences are in the range of about 2%, but that's only over a period of 2 years. So you can imagine that there are some individuals who are going to progress faster as their cognitive function drops, and others that will progress slower. And while this is early stages of this research, I think this kind of a stratification into different lanes at which, or different speeds at which patients are going to progress becomes even more important as our potential for interventional strategies evolve, and we try to identify those who will potentially benefit the most from any sort of intervention that helps to prolong the development of neurodegeneration or slow it down. Now, coming to machine learning, there's obviously a lot of promise in trying to integrate all of this data into a pipeline that can give us information which becomes difficult to utilize individually. And this pipeline includes data of the images that we discussed, OCT and OCT angiography. It includes quantitative numerical data that is obtained from the measurements of thickness of different regions within the retina in that grid that we discussed, the ETDRS grid, measurements of vessel density, perfusion density, measurements of the larger vasculature of the retina that can be obtained using fundus photographs. So all of these serve as inputs into this model along with the raw images themselves. And that allows us to construct a real multimodal based model for trying to distinguish. Initially, our efforts were to try to distinguish those with Alzheimer's disease from controls with normal cognition. And we found that the model performed quite well and stabilized after about 50 epochs. And we also looked at the performance of the model using the different inputs. And what was important to note is that the performance varies based on how many inputs you provide. And an optimal model uses basically all of the data. So all of the images and data performs quite well. And even if you restrict it to OCTA and some quantitative data, that also does quite well. So the important thing here was you could potentially leave out fundus photographs and just use the OCT and OCTA data and still obtain AUCs that are better than about 0.8. And that was an important learning point for us, is that it perhaps speaks to the fact that because the changes are, we're suspecting the changes to be at the level of the smaller capillaries and the microvasculature, that really focusing on development of OCT and OCTA and prioritizing it over photographs may be valuable. Because at the end of the day, as we try to refine retinal imaging as a biomarker or as a screening tool, we really want to hone into the imaging devices and scans that are going to be our highest yield, because we want to minimize scan acquisition and also simplify the scan protocols. So this is just an example, where the model said that this patient here, this is a montage of images taken from a patient. So you can see that there's an OCT angiography image in the top left. There is a color fundus photograph image on the bottom left. The central image in the bottom, the gray colored image, is an autofluorescence image. This is an image that picks up the reflectance of the retinal pigment epithelium. And we have been acquiring these images as well and trying to study how that fits into the detection of neurodegeneration. And then there are thickness maps of the ganglion cell layer and the retinal nerve fiber layer. The purple and yellow image that you see in the top center is the saliency map that was picked up, that was constructed by the model, showing areas on the OCT angiography that it felt was important. But overall, these are images from an 85-year-old that has Alzheimer's disease. And the model said that the probability of this patient having Alzheimer's disease was strongly predictive. Now, conversely, this is a montage of images from a 72-year-old with normal cognition. And you can see that there are clear differences between at least the thickness of the retinal layers that can be seen. And this, the model said that this probability of this patient being controlled was high. And you can see that the saliency map is identifying areas, including the foveal avascular zone and then some of the areas around the capillaries. Next, we tried to see if we could potentially move this model up a stage. So basically going from those with symptomatic Alzheimer's disease to those with mild cognitive impairment, but not yet having a diagnosis of Alzheimer's disease. And this time, because we had learned from our Alzheimer's disease model that fundus photographs may not be the highest yield, we focused in on OCTA and the OCT quantitative data and used that as inputs. And again, found that the model did reasonably well. And it was a combination of using the OCTA images along with the thickness data and the quantitative data that gave us a good performance. And this becomes even more important because these are otherwise well-functioning individuals. They do not have dementia, but yes, they do have some level of cognitive impairment. So the fact that you can potentially pick up differences in an automated manner in this cohort is, I think, very, very important. But just to reemphasize that all of these models are contingent on having a very strict adherence to scan quality of the images, because the differences that we are trying to detect are very subtle. So if there are quality issues with the images, that's going to throw off the model. And one of the impetuses for us to develop the quality model were the struggles that we observed in the initial machine learning attempts when we were seeing signals that are all over the place, and on further reflection, it was partly because of the quality of the images. So just to conclude here, that the retina continues to be a very promising biomarker in neurodegenerative diseases. Retinal imaging like OCT, OCT angiography are promising. There are also other retinal imaging techniques like you may have heard of. There are techniques like hyperspectral imaging. There are techniques that are based upon detecting fluorescence of markers like curcumin that are also being investigated, particularly in their application towards neurodegenerative diseases. There's also a lot of interest in blood-based biomarkers. You may have heard that there are some CLIA-certified blood-based biomarkers that may detect levels of amyloid and tau in the blood. And it may be that the ultimate biomarker for early detection is a combination of a retinal biomarker and a blood-based biomarker. One inherent limitation of retinal imaging remains the lack of specificity of these changes, because the retina is a neurovascular tissue. So any kind of insult to the CNS or to the retina itself can result in either thinning of the retina or loss of the blood vessels. So one important thing is that all these patients that we have collected, and we have over 5,000 patients in our database now, these are patients that do not have other comorbidities that could impact retinal measurements. So i.e. diabetes, uncontrolled blood pressure, demyelinating disorders like multiple sclerosis, ocular conditions like retinal pathology, glaucoma, because all of these confounders will impact your measurements. So at the moment, the applicability of this kind of imaging is limited to those that don't have these ocular comorbidities and that don't have systemic issues that could impact retinal imaging. So down the road, one of our efforts is going to be to see, is it possible to try to detect the patterns of insult from, for example, diabetes and hypertension, and are they different from what we would see with neurodegeneration? And with that, I would like to acknowledge all our team members in the iMind Lab at Duke. And we have the link to our website at the bottom. So all our team members, and particularly my collaborator and co-chair, Dr. Sharon Vekrat. And thank you very much for your attention. And I would like to open this up to questions.
Thank you very much, Dilraj. Any questions in the audience? Yes.
Yeah, thank you so much, sir. So I have two questions, in fact. One of them being how reasonably can we correlate retinal images with features like hippocampal degeneration, which have now, or atrophy, which have now been identified. for neurodegenerative diseases? And number two, do we have some kind of open databases with fundoscopy or OCT images which we can start working with initially before getting some kind of a, before proceeding further? Thank you.
So to answer your first question, yes, there is data that as you lose nerve tissue, you will see some expansion of the ventricles and you'll see some loss of the hippocampal volume. One of the challenges becomes that, and this alludes to your second question, is that these data sets at the moment are quite specific to the device and the software on which they have been acquired. So for example, our data set cannot be necessarily compared to a data set that's acquired on another platform, or even with a significantly newer version of our device. So that makes it more challenging to pool these data sets, particularly as we're trying to get more correlations between, for example, volumetric MRIs and retinal imaging. There are, to my knowledge, it's difficult to get access to an open source data set, because as you can imagine that there's a fair amount of effort that goes into from a neurologist standpoint of giving a diagnosis of Alzheimer's. Data sets also differ in terms of how they define Alzheimer's. So for example, some institutions require the presence of amyloid PET for every patient that is classified as diagnosed as Alzheimer's. But that is not something that is standard of care, and that is not something that is reimbursed by insurance. So in clinical practice, most clinicians, most neurologists do not obtain amyloid PET when they're staging Alzheimer's. The second issue with databases becomes the heterogeneity, like I was discussing, of retinal imaging and also of their classification. And this is a key problem. There's some large population-based data sets like the UK Biobank, where you can submit an application to request usage of their data. They may not share the actual images with you, but you can potentially submit an application and request them to run certain searches or certain assessments within that database.
Anyone else? Yeah. Okay. So I have one question which maybe you kind of covered, but you talked about the heterogeneity and the age-related, normal age-related changes in the retina. So is there any possibility of a longitudinal study of the same individual retina being imaged every 10 years and associating that? Some fraction of the individuals in the study may end up getting some kind of neurodegenerative disorder in their 70s or 80s. And
yes, that's on the wish list for sure. So, we have been imaging patients now for about the last 7 years. There are other banks, like the UK Biobank, there are Scandinavian countries that have population-based studies in which they image patients. One of the challenges becomes that, the data that was acquired even 10 years ago on retinal imaging is not to the same level of detail as what we have now. So a lot of these population-based data sets that have been done in Scandinavia and the UK, that data is pretty rudimentary compared to what we can obtain now. But the problem is, in order to look at change over time, you want to maintain the imaging on the same instrument. Because if we update the instrument, you can't compare the measurements. So that's been an ongoing issue with longitudinal data sets, is that when is your cutoff for saying and freezing the image parameters, knowing that the technology changes so rapidly that every 5 years there's pretty much a paradigm shift in your retinal imaging.
Okay. Yeah, that's challenging. And that's probably not unique to, maybe it is unique to retina because I think PET and CT and so on don't evolve that rapidly. So, there's a question back there.
Yeah, I don't have a very clear-cut question, So it will be a bit vague, but I'm just curious that since Alzheimer's is an predominantly age-related disorder, so in the population that you have studied, is there, have you thought about something like what would be the age interval which people who are healthy right now, but would likely develop the disease in the future? And what would be that interval of intervention for a disease like this?
Right. So, that's a key issue. If you look at etiologies of Alzheimer's, yes, age, environment, but there's also a genetic component to it. There are certain genes that put you at risk for developing Alzheimer's, particularly you're biallelic for them. For example, ApoE4. And there is a subset of patients that develop early onset Alzheimer's, and that can be more rapidly progressive. In our cohorts, we have limited imaging to patients who are 50 or older. And that's where the majority of the changes you would start to see. But if we have a data set of patients that have been tested genetically for the marker and tried to image them even early on, in that data set, we did not find differences when we imaged patients at an earlier age. But is it conceivable that if we continue to follow those patients that are at genetic risk, would they develop changes earlier? Yes, they would. The question then becomes, though, that how valuable is it, because you already have the genetic profile that already tells you that they are at risk. So that does become a little bit of an issue, but there is definitely value because early onset AD will have the poorest prognosis in the long run.
So just thinking aloud, you mentioned, you showed a slide of a whole bunch of risk factors for Alzheimer's and a bunch of protective factors from Mediterranean diet or keto diet and lifestyle and so on. Plus, as you said, the genetic profile. And so is anyone working on a machine learning approach to putting together all of these as well as retinal scans? Because retinal imaging by itself may be too noisy, but combined with other risk factors may give you a better prediction of the risk score of the individual.
Yes, the one issue is that, as you can imagine, the neurologists also have different opinions, and that slide was more of a public education kind of slide. There is, if you really distill it down to what the evidence says about risk factors and what level of evidence each of those have, the opinions differ. And then it's also different in terms of recording things like that. Now, one metric that we have been recording is years of education, because that is something that is very distinctly associated with cognitive function. So basically, the longer you study for, the better are your chances of preserving your cognitive function. And that actually holds true independent of your genetic risk factors. So even if you have two cohorts that, let's say, have the ApoE4 gene, but one has significantly longer years of education, their onset of dementia is delayed. We have also looked at some of the other risk factors, like, for example, smoking, hyperlipidemia, hypercholesterolemia, things like that. As of yet, have not found a clear-cut signal. And part of that is because when you get into those kinds of risk factors, then you're talking population-level numbers. And for population-level study numbers, to get that kind of a data set where you have tens of thousands of people with rectal imaging, that's going to take time. Because remember, you also have to have a careful neurological stratification for all those patients. It's not just saying risk factors, but each patient has to be assessed by a neurologist comprehensively, potentially undergo neuroimaging. So all of that takes up a considerable amount of time and resources. But yes, that is something definitely that's being looked at.
So one of the protective factors on your slide was moderate alcohol consumption. And I was curious because a lot of recent headlines say no amount of alcohol is safe. And I mean, in general, not about neurodegenerative diseases, but when you said moderate, was it as opposed to extreme or was it as opposed to zero?
Opposed to extreme.
So 0
Yeah.
is still better.
Well, that's a little bit outside the scope of this talk, but in general, you're right. There's a lot of controversy in it, right? And that slide is more of a public education slide, and I won't go into much detail on it. There are different schools of thoughts. In general, though, moderation is good with everything.
Okay, yeah, one more question.
A wonderful talk. So retinal imaging is a way to look for the neurodegenerative diseases, but one can also reverse it to ask whether the advancement in the treatment of neurodegenerative diseases can help in treating some of the eye diseases.
Yes, so that remains a holy grail for us. Some sort of a neuroprotective effect in the eye has been on our wish list for a very long time, not just for retina doctors, but also for example, glaucoma doctors, to protect the optic nerve. And if you want to take it a step beyond that, if you have some sort of a neurorestorative treatment that can potentially restore nerve fibers around the optic nerve or retinal epithelial and photoreceptor cells, then we are talking of vision restoration, not just vision preservation. That's a different line of research, which is challenging, very exciting. You may have heard of programs like injecting progenitor stem cells underneath the retina or in the vitreous cavity to try to take over the function of some of these cells. It's still in the early stages. There are safety issues with all of these technologies. There are also issues so far as to how well these cells function when we try to program them, because it's different programming a stem cell to take over the function, for example, of bone marrow, versus programming it to take the function of a rod or a cone cell, which is such a specialized cell in the retina. So it's definitely exciting, and it's work that's being pursued by several groups across the world. And yes, it is certainly something that we would all love to have.
Thank you.
Any more questions?
Hi, nice talk. So what I understand is that studies, they have shown that there is a strong correlation in the diversity of microbiome and the neurodegenerative diseases like Alzheimer's. So I think it would be great to couple microbiome in the current study for the machine learning purpose.
Yes, it's a great idea. I agree with you. As you are aware, one of the concerns with, as you incorporate more variables, you need more money.
Yes, and also would be great to increase the diversity by including prebiotics and probiotics in the diet.
Yes, I agree with you.
Any more? Okay, so let's thank Dilraj again for a very interesting talk. And this is obviously something that's evolving fast, and we look forward to more interactions maybe. Thank you, Dilraj.
Thank you. Bye.